Assalamualaikum and hi Mr. Saiful Adli. My name is Nur Alia Natasha binti Mat Taib. Today I'm going to present on the movement impairment and motor control in patients with patellofemoral pain syndrome (PFPS). It is a case study. So to begin with, I'm going to start with anatomy and physiology of patellofemoral joint or PFJ. It is one of the major joints at the knee, and patella is the flat triangularly shaped largest sesamoid bone in the body that is embedded within the quadriceps muscle. The stability of the lower limb is affected mainly by vertical position of the patella and also related to the patella tendon. The PFJ reaction force influenced by both quadriceps force and the knee angle. For example, during knee flexion or extension of the patella is pulled superiorly by the quadriceps and inferiorly by patella tendon. But again, it depends on the range of the knee flexion. And if patella orientation or the alignment is disturbed, it will glide to one side and causes overload on that part, which results in pain, discomfort, or irritation. Next, the patellofemoral pain syndrome are actually an anterior knee pain, and it is commonly happen in young active populations, but particularly in female due to female biomechanical structure. Okay, the pathophysiology of PFPS could be due to overpronation of foot, increased Q angle, VMO or vastus medialis oblique weakness, and muscle imbalance often seen within the muscles of quadriceps and hamstring. This syndrome usually aggravated at functional movements such as squatting, going up and down stairs, transferring position from sitting to standing position, and also an excessive flexion of the knee. And the symptoms in patients with PFPS, they usually feel unstable during standing or walking, localized pain on the patella region, occasionally crepitus sensation, edema on the patella region as well, and obvious feeling of muscle weakness. So the assessment, we are going to use a movement system impairment MSI diagnosis associated with knee pain because it was used in a study by Harris Hayes et al. On 2008 that the study uses MSI to identify the movement impairment in PFPS. Only that the study by Harris and colleagues has also identified that the tibiofemoral rotation is the largest predictor of patient with PFPS. The table on this side here shows that identifies the abnormal rotation of the tibia and femur, but we can also use the test item in this MSI system to find out what are the movement impaired in patient with PFPS. Next, the exercise intervention mainly for PFPS patient we will use according to a case study by Golden E on 2015, which demonstrated an 8 weeks treatment intervention for PFPS. So in this study, 60% or 3 out of 5 athletes with PFPS showed an improvement in hip and quadriceps strength, better motor control VMO, and able to return to sports. Moving on, so this case study was taken on 3rd of February. The name is Mr. Y, age 21 years old, a male patient, and he was diagnosed with right patellofemoral pain syndrome, and the management from the doctor was conservative treatment, which is to refer to physiotherapy. So we'll start with the subjective assessment. Patient firstly complained with aching pain and weakness on the right knee while running and going up and down stairs, and then upon asking for visual analog scale, patient said it was 4 out of 10 scale of pain on the right patella, and on the body chart it was identified that the pain was on the right patella region. It is an aching pain and it was anteriorly. The nature of the pain is aching. Aggravating factor was the pain worsened, especially when running downhill compared to uphill, while for ease factor, the patient will sit with the knee extended and rest. The 24-hour behavior in the morning, patient experienced minimal to no pain from waking up from sleep, while at day, the pain triggers after prolonged walking, approximately more than 30 minutes, and going up and down stairs, while at night, there are no difficulties or pain during sleep. Irritability, which is moderate because based on aggravating factor, while severity is also moderate based on VAS, which shows moderate pain. Moderate pain is usually 4 up to 6 VAS. The current history was that the patient experienced gradual onset of knee pain around right patella since last 2 weeks. He went to Polyclinic Icro on 29th of January and was diagnosed with PFPS, and the patient was then referred to physiotherapy for conservative treatment. Past history was the patient changed his running location to a hills location just at the back of his house since November 2020 instead of on field track on MMU due to COVID-19. And then back in 2019, patient had right patella dislocated while playing volleyball. Ever since he stopped playing volleyball, but he did not receive any treatment. There are no identified past medical history. For social history, patient is MMU media student. He was also a marathon runner. Last joined marathon event was on June 2019. He is a non-smoker and he usually spends loads of time in front of computer, study, work, and hobby, which is running. There are no physical history. Medications, patient was given painkiller, but so far he did not take any painkiller because the pain is not, it is still tolerable. While on investigation, on the same day, he went to doctor. He made an X-ray, and there are no abnormalities detected. An objective assessment, we are looking at the general observation. The posture is mild, kyphotic, and rounded shoulder. The body figure is ectomorph. Patient able to ambulate independently without any support or walking aids. The gait was observed by a reduced knee extension in the loading response and terminal stance. Local observation, there were no bruising, no redness, cuts, stitches, or bony abnormalities. On palpations, there are pain at right patella tendon and vastus lateralis muscle. And there are mild heat on right patella tendon. Lastly, there are tenderness palpated with grade 2 tenderness on right hamstring muscle. So the movement impairment test. Alright, we'll start with the standing position. A single leg stance with feet apart, arms folded. Alright, so we started to stand on one leg with eyes open and arms crossed for as long as he can, and then the therapist take the time. So started on the left and then go for the right side. We observe that the balance during eyes open are only 5 seconds and 3 seconds when eyes are closed. And then there is also observed excessive trunk oscillations, increased lateral hip drop, and also the hip is not maintained in neutral position. While on the left side, the balance is greater than 30 seconds with both eyes closed and eyes open, and there is no abnormalities during the hip, pelvic, and trunk. So this means that the right balance are impaired. There are poor proprioception at foot, knee, hip, spine on right side. There are weak superficial abdominal muscles, tightness of the right hamstring, and muscle imbalances involving gluteus medius or maximus, the tensor fasciae latae muscles, and iliopsoas muscle. Still in standing position for half squat test. So during this squat test, we have to observe the lumbo-pelvic position, which is obvious that the patient unable to maintain the lumbo-pelvic neutral position. And then at the hip and knee level, there is an increased hip internal rotation, and the knee will immediately translated to first toe. And then observe from the tibia, there's also excessive external rotation of tibia and loss of ankle joint neutral position. Then patient tend to lean weight forward onto toes, and there is poor balance during half squat, and compensated with excessive trunk flexion. And then this indicates that there is poor core motor control, tightness of erector spinae iliopsoas, rectus abdominis, vastus lateralis, TFL soleus, and weakness of the gluteal muscles, VMO, and tibialis posterior. And patient unable to perform or to progress further squats because of the pain when patient is going into more increase in flexion. So patient only able to do a half squat movement impairment test. And also patient unable to do lunges because lunges involve very much of a degree in knee flexion. So that's why patient will proceed with the test of going up and down stairs, step up and down. So during this test, we are going to observe the knee and foot control. At the right side, there is a quick step off, heavy landing while going down on the right side, and then patient use of support on lowering, trunk lateral flexion on lowering, while on the left side there is no abnormalities detected. Implications were the poor eccentric control of hip extensors, quadriceps, and calf muscles. Also poor control of deep hip stabilizers, pain with eccentric loading, and trunk pelvic compensations. So there is a heavy landing while on the right side, and patient also tend to take support. Okay. Alright, and the last test is the sitting for alternate knee extension and ankle dorsiflexion. So we are going to observe mostly on the right side. So on the right side, there is an obvious of the medial rotation of the knee during extension, reduce knee extension and dorsiflexion of ROM, increase ROM of knee extension in slump position. So therefore, it indicates that there is the tightness of the right hamstring, gastrocnemius, dominance of TFL in movement pattern, and there's also weakness in quadriceps muscles, and the slight stiffness of the right hindfoot because of limited of the dorsiflexion. Alright, so for analysis and treatment, problem listing, the body impairment based on ICF. The body impairment is aching pain on right knee anteriorly with VS of 4/10. There's a mild hit on right patellar tendon, grade 2 tenderness on right hamstring muscles, poor balance and proprioception of right foot, knee, hip and spine, reduced RM of right knee extension and ankle dorsiflexion, weakness of right VMO and abdominis muscles. Everything limited as seen in gait pattern with reduced knee extension, difficult to perform squats and unable to prolong walk and ascend and descend stairs, participation restriction, difficult to train for running at his location. So impression physiotherapy, where patients having right PFS due to change of location for his training or running from on-track fields to hills location, and there's obvious impact gait pattern on right side, difficulties to perform single leg stands, squats, step up and down, all those limited range and weakness muscle due to poor core motor control, weakness of VMO, and abdominal muscle and tightness on right hamstring, and also difficult to train for his running on hills due to pain and weakness of VMO muscles. Treatment goals, for short-term goal, we are going to reduce heat and pain on patella in 2 or 3 days, to increase RM of right knee extension and ankle dorsiflexion in 1 week, to improve muscle strength of right VMO and abdominal muscle in 2 weeks, to regain normal gait pattern and by improving core motor control RM of right knee extension and dorsiflexion in 2 weeks, to improve balance and single leg stance with both eyes closed and eyes open, and also to improve performance in squats and step down in 3 weeks with the test retest. So for long-term goal, patient to get patient to return training on hills without pain and limitations. Treatment interventions. So there are 6 treatments. This patient will start with the wall squat. So patient is instructed to lean their backs on the walls with both foot forward, foot distance or shoulder width. Patients are instructed to flex the knee up to 40 degrees without holding the breath, leaning the back downwards, and the therapist will position their hands on both of the knee to ensure that there is no misalignment of the knee laterally or medially. So patient hold in 5 seconds, and this should repeat for 10 repetitions with 2 sets. The next exercise is the VMO contraction exercise, where patient is in sitting and knee flex in 90 degree. Patient are using 1.5 kilogram weight on the right side just above the ankle joint. So patient is asked to extend the knee as high as possible without any change in position of the lumbar or extended at the hip, and hold for 5 seconds. Repeat for 10 times, 2 sets. Next is the hip extension in standing with the same weight on the right side. So patient just need to extend their hip backwards with the knee flex and hold it for 5 seconds. So this exercise should be repeated for 10 repetitions as well with 2 sets. While doing this exercise, the lumbar should maintain in neutral position. It shouldn't be flexed forward. Alright, on the next exercise is a hip abduction in standing position as well. So with an ankle weight of 1.5 kilo to begin with. So patients are instructed to abduct their hip on their side with hands supported towards the wall, and same, hold for 5 seconds, repeat for 10 times or for 2 sets. And then next is donkey kick. Donkey kick is patients are in quadruped position on 4 points with the whole spine in neutral position, no hyperlordotic or kyphosis. So while maintaining this neutral position of the spine, patient is instructed to extend their hip up with the knee flex. This is to activate the abdominals, the glutes, and the erector spinae as well. So during the activation, the patient should hold for 5 seconds and repeat it for 10 times and for 2 sets as well. The last exercise is the balance training. So in balance training, patients are going to train their proprioception of the hip, knee, and foot together. Started, hands can be at their side. Patients should try to achieve up to 10 seconds to begin with and progress with 15, 20, and up to 30 seconds with both eyes open and eyes closed. Therapists should be on their side for safety measures. So the exercise for wall squat, it targets the muscles of the quadriceps, hamstring, as well as the abdominals. It is a modification from the Swiss ball squat exercise because we don't have the equipment. The VMO contraction targets the VMO muscles contraction, reactivate the muscles. The hip extension target the gluteus muscle. The hip abduction targets mostly on the TFL muscle. Donkey kick targets the muscles on the glutes, so abdominals and the back. Balance training to improve their proprioception. The exercise here should be done 3 days per week with 1 or 2 days gap. Alright, conclusion, patient was developing patellofemoral pain syndrome the moment he changed the location of running from a track field to a more hills location. Patient started to have right anterior knee pain, maybe due to the dominant side of the leg, along with other symptoms such as muscle tightness and weakness. The symptoms limits functional movement of patient in daily activities. Movement assessment helps to identify on which muscles need to be treated accordingly. Exercises intervention started with reactivating the VMO and strengthen the weakened muscles, then further develop muscle control of the knee, hip muscles, and improve proprioception. Lastly, patient will be reassessed on the movement assessment for his progress. That's all from me. Thank you.